but it might work in other cancers where the immune system is not sufficient currently to really produce these kinds of responses.
No, that's all. Those are really great. So, I mean, I know we're kind of running out of time. You and I can chat about this for another hour or so. Um, one of the thing is, you are in the forefront and you're not only seeing patients, but you're also doing research. What can you tell patients at this stage, so who have, early stage of melanoma versus someone who has advanced stage of melanoma? Because everything we say, there's an enormous power of healing, I think, right?
Yes.
What kind of pearls of wisdom do you have?
So I think the striking success that therapies have seen in melanoma is actually marching on. There is even more, and even though we're almost out of time, I'll quickly try to summarize. One aspect that I think is one of the most exciting, very recent developments within the last 1 to 2 years, and that is taking these treatments that were given to patients with metastatic melanoma and moving them up to earlier stages in the development of melanoma. So when it's still confined to the skin, but where we know, based on its thickness or based on local spread to lymph nodes, that these people have a statistically elevated risk that even after it's been fully removed by surgery, they could have a relapse. And unfortunately, that is the case for a significant fraction of patients with melanoma at earlier stages. And so some recent trials have tested those very same drugs now in the earlier phases and seen significant benefit, major benefit, as measured by the lower likelihood of relapsing within a couple of years afterwards. Unfortunately, these data are so recent that we don't know whether these are the same patients who, if they did relapse, would have been cured by those drugs at the advanced stage. And that's a terribly important question. We need to learn the answer to that question, because there's an uncertainty about whether to give these drugs to patients with early stage 2 or stage 3 melanoma, because the majority of those patients are never going to relapse after the surgery is done. So once again, we have this predicament. We could give a drug that may lower the risk of relapse, but many of those patients are at risk of side effects. And so if you didn't need it, if that tumor would never have relapsed anyway, you would certainly not want to expose those patients to that risk. So again, as you asked before, how can we tell which patients are going to benefit and which not? Research is terribly important to try and figure that out. What features will predict the patients at greatest risk of having a relapse and potentially responding to these drugs, so that we can really appropriately tailor the therapy for the patients who will benefit from it the most. But coming back to your bigger question, I think, which is for the patients who have melanoma right now, family members or patients who are at risk of having melanoma, many people would say in the history of the disease, this is the time to get it, if God forbid you need to get it, because we have greater tools than we ever have had before. And the research engine is running, and it is running at 100 miles an hour. There are discoveries constantly coming out. There are improvements constantly coming out. So for myself, I think I would speak for many of my colleagues, this is a very optimistic time in the field. We're not where we need to be. There's much work to be done. But we are learning so much. And again, because it is based on the science and the mechanism of the disease, we really think we're getting it in the corner here. It's stuck. And we don't have yet all the tools we need, but we know the questions better and better. And hopefully, as those tools come together, the therapies will really reach where we think they have to be at the end.